Hello everyone. Today we are going to talk about bioavailability and factors which affect bioavailability. First we will talk about definition. Bioavailability is about amount or percentage or fraction of the drug that enters the systemic circulation in unchanged form following use of any dosage form. In any dosage form. What I mean by this is either tablet, capsule, IM, IV, whatnot, everything here. Clear? So these are the parts of the definition of bioavailability. So basically, bioavailability talks about rate and extent of absorption of drug. That's the basic difference between your bioavailability and absorption. Now we will talk about how is this calculated. Let us say this is the graph. Okay, in this talks about time and y-axis is about concentration, plasma concentration. Okay, now let us say I have used three drugs. Drug A, formulation A, or formulation A, formulation B, formulation C of the same drug. Okay, now I have given formulation A here. For any drug based on the already done research, we will find out what is the there are two important parameters. One such parameter is minimum effective concentration and the other one is maximum safe concentration. Clear? This is about effective, minimum effective concentration. Now, for formulation A, I have given it here, and immediately after giving, the concentration has increased and then it has fallen down like this. Okay, now let us talk about one more. This is same drug, other formulation. Now I have used some other formulation. It has stayed like this and it has stayed for this much time. Now we'll talk about other formulation of the same drug. It is something like this. Clear? So we are talking about same drug but different formulations. Now considering this, if the concentration, serum concentration has crossed the maximum safe concentration which we have derived from already done research, it means that this formulation there is very high chances of side effects. Clear? And it is should not be used. Now let us say this. It did not even reach our minimum effective concentration, this formulation C. So do you think that is correct? No. Clear? So this is also not effective because it is not at all useful. It is not showing any effect. Now let us talk about formulation B of the drug. It is in the safer zone where minimum effective concentration is crossed, maximum safe concentration is not crossed, and it stays in this duration for longer period. In this part for longer period. So this formulation of the drug is approved. Clear? How come we know all this? We are calculating plasma concentration. So for this graph, there are certain other parameters also which we should know. Now we found out the formulation. Yes. Now we need to understand the bioavailability concept here. Yes. So let us say we have got formulation B as our standard formulation. Now I have used the same formulation. Now it is reaching and it has crossed. Okay. Now this is my highest concentration. Yes or no? This is my highest plasma concentration. This point is called Cmax. Clear? Now this is time. This point is called Tmax and the whole graph area covered under this is called as area under curve. Clear? So we got three parameters here. One is Cmax. Cmax is maximum concentration. The other one is Tmax. Tmax is time taken to reach the maximum concentration. And then AUC is area under curve. Clear? These two helps us in understanding the rate of absorption. Is it fast or slow? Clear? In the same way, area under curve helps us in understanding extent of absorption. This will tell us about is it completely absorbed or incompletely absorbed or anything else. Clear? Now, bioavailability is designated by the letter F and is calculated area under curve after oral dose followed by area under curve after IV into 100. So this is how we calculate bioavailability. So if a question comes for 5 marks on just the bioavailability, this is what you have to write. If the question also asks about factors affecting bioavailability, then you will start enumerating them first. These factors are primarily drug related as well as patient related. Clear? Drug related, see, drug is a foreign body, it's a physical entity. So physical properties of the drug as well as your dosage form. With respect to physical property, physical state. In the same way, solubility. With respect to dosage form, particle size. Second is your disintegration and dissolution. Both are times, disintegration time and dissolution time. In the same way, third one is your formulation. These all come under your factors. Now, we will talk about patient related factors. This is what we are much more bothered. With respect to patient factors, first thing is your physiological factors. Physiological factors mainly include ionization and then pH of the GI fluids, GI transit time, enterohepatic cycling, first pass metabolism. In the same way, presence of other agents. This is physiological factors. In the same way, we have second important pharmacogenetics and pharmacogenomics. Obviously, third most important is patient's diseased conditions. Clear? So, factors are either drug related or patient related. First, we'll talk about drug related factors. Physical properties, yes, and solubility. So, complete in drug related, we are talking about physical properties. In physical properties, we are talking both physical state of the drug, and then solubility. With common sense, we can tell that solids are less absorbed when compared to liquids. Yes or no? This is just an example. In the same way, solubility. More the solubility, more is the absorption. It's as simple as such. Yes. Now this is about your physical factors. Now dosage forms. In dosage forms, we saw three. First thing is particle size. Smaller the particle, more is the bioavailability. Second parameter is disintegration time. What I mean by disintegration time is, let us say a particle must be broken down into finer particles. Yes or no? This breaking down time is called as disintegration time. Clear? So, more the disintegration time, more the disintegration time, less will be the bioavailability. More the disintegration time, less will be the bioavailability. Now we will talk about next parameter, that is dissolution time. All these smaller particles must be dissolved in our stomach fluids. Yes, so this is more the dissolution time, less will be the bioavailability. Am I clear with this? Now we will talk about formulations. There is not much more to add, but there is something very important concept here. What we call it as, see, usually let us take example of paracetamol. In a tablet of paracetamol is only 500 milligrams. 500 milligrams, but this paracetamol will be much more, this paracetamol tablet will be much more high weight. Why? Because we add excipients. These excipients are inert substances. They don't play any role. They increase palatability or something, like very little effect on absorption. Usually, we add calcium or magnesium for majority of the drugs. This is about your drug related factors. So, we have finished this. Yes. Now we will talk about patient related factors. This is what we are much more bothered. We as healthcare professionals are much bothered about this. Now, in patient related factors, first one is physiological factors. Yes, in physiological factors, we will start with most important, ionization. Clear? Usually, let us say we have an acidic drug. Let us say acidic drug stays intact in acidic medium. Yes, whereas it ionizes or it becomes salt. Yes or no? In a basic medium. In basic medium, and always intact drug is better absorbed. The same stands for basic drug also. It is intact in basic medium, whereas it is ionized in acidic medium. Clear? Only intact drug gets absorbed. Fine. Now with this background, let us take example of aspirin. Aspirin is acetyl salicylic acid, so it's an acidic drug. It gets absorbed better in stomach and less in intestines. This is my acidic drug. Now let us consider some others like lignocaine. Lignocaine is better absorbed from intestines. Sorry, lignocaine is never given orally. So tell me one basic drug which is very commonly used. Aminoglycosides, the very strong basic drugs, lignocaine, all these. So they are better absorbed in intestines and less absorbed in stomach. Clear? This is with respect to ionization. The same with respect to our second feature also, that is pH of our bodily fluids. Yes. Now third factor is GI transit time. More the transit time, more bioavailability. Clear? And now we will talk about next factor, that is enterohepatic cycling. Here we need to understand certain basic concepts. This is liver, okay, and this is my stomach, intestines. What usually happens is, from portal circulation, drug reaches liver. Yes, in the liver is a place for metabolism of foreign products. Obviously our drugs are foreign bodies, so liver metabolizes drugs and excretes them in gallbladder, and again through biliary system it reaches my lower intestines. Yes. After reaching lower intestine, our intestines have bacterial flora. Bacterial flora for some drugs reverses whatever liver does, resulting in formation of active drug. So again through portal circulation, drug reaches liver. From here obviously certain part will reach my systemic circulation. Because of this enterohepatic cycling, drug stay in our body will be prolonged, so that for longer duration drug is available. For longer since drug is available for longer duration, it increases bioavailability. Am I clear? I'll explain this with an example. Estrogens are metabolized in the liver with the addition of glucuronide conjugate. In the liver, it gets metabolized. Whereas in the intestine, with the help of bacterial flora, deconjugation happens. Because of which, again, active estrogen will be there. This estrogen again reaches liver. Some part reaches systemic circulation, some gets metabolized into and through biliary system, it reaches the intestine. Am I clear? More the enterohepatic cycling, more is the bioavailability. Now, let us talk about our fifth factor, area of absorbing surface. More the area, more absorption. It's as simple as such. More bioavailability. Then, next one is first pass metabolism. We need to talk about this a lot. See, what happens is, when we take a drug, same story again, my liver, it is reaching systemic circulation. This is my stomach, my intestines. Clear? Now, when I take a drug orally, let us say I have taken 100% of drug, some part of the drug reaches liver through portal circulation. Let us say around 90 has reached my liver, 10 gets excreted unabsorbed. Okay, now in this 90, my liver thinks that this is foreign object. So it starts metabolizing. Let us say it has metabolized 10%. 80% reaches systemic circulation, 10% gets excreted again through biliary system. Clear? Whatever reaches the systemic circulation, from here it reaches my heart, from here it reaches my all organs, and effect is shown. So even before entering systemic circulation, some part of the drug gets metabolized. This is called as first pass metabolism or pre-systemic metabolism. And this more the first pass metabolism, less is the bioavailability. Fine. Now we will talk about next factor, that is presence of other agents. See, with respect to this, best example is iron. Iron is always combined with vitamin C so that its absorption, bioavailability increases. It's as simple as such. This is about more your factors, physiological factors. Yes. Now we will talk about pharmacogenetics. See, pharmacogenetics alone is an other class. It's important. It's very, for now here with respect to bioavailability, what you need to understand is certain patients are genetically different, because of which their bioavailability of the same drug varies. This we call as pharmacogenetics, and we'll deal about this later. Now, diseased conditions. With respect to diseased conditions, you need to understand some few important things. One such is, let us say a patient has malabsorption syndrome, topical screw, malabsorption syndrome. Then your absorption bioavailability automatically reduces. In the same way, a patient has a liver disease. Obviously, metabolism of the drug reduces. Your first pass metabolism is changed, everything. So, bioavailability varies. Let us say renal disease. In the case of renal disease, drug will be excreted lately, because of which prolonged duration of drug stays, so that bioavailability may change. These are examples only. With this, all the factors are finished. Now, we will understand one most important thing, effect of bioavailability because of route of drug administration, oral or enteral. Let us fix ourselves to enteral route, enteral, parenteral. Yes, in parenteral we have IV, IM, subcutaneous. Enteral has many routes. All factors affect bioavailability when they are given by enteral route. Parenteral route, that is intravenous route, has 100% bioavailability. Intramuscular and subcutaneous varies something between enteral and parenteral. So IV has highest, IM and subcutaneous are between, whereas enteral, let us fix restrict ourselves to oral, has less bioavailability, because all factors play a role in absorption when a drug is given by oral route. In IM and subcutaneous, blood supply to the muscle plays an important role in bioavailability. Clear? I think with this we have finished bioavailability. Thank you for patient listening.